Good afternoon, everyone. So afternoon session is the slide seminar, which is really honoring Dr. Stewart. We kind of wear our general surgical pathology hat on and listen to really interesting cases that some of us will not see because we don't sign out those subspecialties. So with that, let me introduce the first speaker. Dr. D'Alfonso, Tim. Tim joined us not even a year. Today I was asking him, he said December of 2017. I said, wow, I really kind of made him do this the first time around. But anyway, I'm so glad he volunteered to do a case. Tim came from Cornell, and he's an associate attending and is a member of the breast team, and look forward to your talk.
Good afternoon. Thank you for that nice introduction, Mira. Today, I'm going to be presenting an interesting and hopefully instructive case. It's actually from the consultation service that I saw before I came over here. So we'll get started. The case is of a 53-year-old woman who presented with a palpable right breast mass. Ultrasound showed a hypoechoic mass measuring 1.6 centimeters, so a core biopsy was performed. This is one of the cores, which shows some pink, mostly fibrous tissue. You see kind of from low power the cellular proliferation here. And we go in a little bit higher power, can appreciate that there's this infiltrative growth pattern through this fibrous tissue, really no stromal reaction associated with it. If we focus in just a little bit higher in this area, we see again that these cells have a very infiltrative appearance. Some of them may have somewhat of a signet ring or vacuolated cytoplasm appearance. In an adjacent core, there was some classic type LCIS. ER, PR, HER2 were performed. This tumor was ER, PR positive, HER2 negative, and so the diagnosis was made of invasive lobular carcinoma, classic type, and LCIS as well. So the patient went on to have a sentinel lymph node biopsy and a lumpectomy. And this is an image from the lumpectomy specimen, which shows kind of a similar cellular proliferation, these infiltrative cells growing through fibrous tissue and fat, a little bit more pleomorphic than what we saw in the core biopsy. This is another area where you kind of see this swirling growth pattern, which is a feature that you can often see in invasive lobular carcinomas, and again, this kind of vacuolated cytoplasm with a signet ring appearance. And some areas even have this nice single file growth pattern that we typically see in invasive lobular carcinoma, and also was seen in the core biopsy. ER was done and repeated, positive. But wait, what am I showing you? What am I not showing you? Am I going to present an interesting case of invasive lobular? Well, we haven't shown you the low power view of this lesion. And if you can see, this is a scanned image of the slide, that the tumor is actually really circumscribed, not typically of what you would see with an invasive lobular carcinoma. Here again, you see the tumor, and instead of infiltrating the benign glands, you have this very pushing border where all these cells that are associated with fat are basically pushing these benign glands aside, and we don't really see any benign glands within this tumor. So at this point, we have a circumscribed tumor that's really pushing. So a cytokeratin immunostain was done, and as you can see, the tumor cells are all negative, and a CK highlights some of these benign glands. A CD34 and Desmond were diffusely positive in the tumor. Taken into account the appearance of this tumor and the circumscribed nature, a diagnosis was made of mammary myofibroblastoma, epithelioid type. There was also some LCIS of the classic type, and of course the sentinel lymph node was negative. So just a little background about myofibroblastoma. It's a benign stromal neoplasm, most often occurs in adults over 50 years old. It was initially described to be occurring predominantly in men, but actually the frequency is pretty much equal between men and women. And I really want to highlight that it has a diverse morphologic appearance and can lead to pitfalls of diagnosing other lesions. That was what occurred in this case. Now, myofibroblastomas are characteristically circumscribed tumors, usually do not contain entrapped breast glands within the tumor. This was a case of a man who was getting a CT scan to look for metastatic disease of another type of carcinoma, and they picked this up and then did a mammo and ultrasound, and you see this very circumscribed tumor. It was taken out, and you see it's grossly circumscribed as well as microscopically. You don't see any breast glands. The classic morphology of myofibroblastoma is the tumor is composed of uniform spindle cells growing in fascicles with associated ropey collagen. You really don't see any atypia or mitoses. You will see variable amounts of fat within the tumor, and also you have these, which are pretty much my favorite cells, mast cells. You can see these sprinkling throughout the tumor. Now, myofibroblastoma is thought to be characteristically CD34 positive, as well as Desmin and ER, and then BCL2 and smooth muscle actin stain variably. Negative for cytokeratins, myoepithelial markers, STAT6, as well as endothelial markers. This is a pretty classic example of a myofibroblastoma, which really shows diffuse CD34 staining, as well as estrogen receptor and Desmin. In some cases, as a caveat, they may show only focal CD34 expression or may lack it completely, which can be a pitfall in diagnosing these. This is a pretty classic example from a 60-year-old male, which showed diffuse Desmin staining and ER staining, and the morphology was classic, but it did lack CD34 expression. Now, myofibroblastomas are a part of this family of closely related tumors, which are typically CD34 positive and show a monoallelic loss of this region of 13q14, which includes the genes RB1 and FOXO1. And other members of this family which share this cytogenetic abnormality are spindle cell lipoma of soft tissue, as well as cellular angiofibroma of the vulva. You can demonstrate this by FISH, where you see loss of one of these red signals. And this has also been investigated whether you can use immunohistochemistry to show loss of RB. Now, loss of RB staining in myofibroblastoma can be diagnostically helpful. It's not 100% sensitive, and I often find it hard to interpret. It really depends on the lab. And it's been studied in a few different settings. This is a study from Fletcher at Brigham, and they looked at 143 cases of mammary type myofibroblastoma. So these are similar to what occurs in the breast, but they actually occur in other areas in soft tissue. In this study, 10% were from the breast. RB loss was seen in the majority of them by IHC, and in fact, 11% of these were actually CD34 negative. More recently, this USCAP study showed RB loss in only about a third of cases that were actually from the breast. Differential of myofibroblastoma includes benign and low-grade spindle cell lesions of the breast, particularly those that are CD34 positive, such as PASH or fibroepithelial tumor, but you always want to, when you have a spindle cell lesion of the breast, rule out a metaplastic carcinoma, particularly some of those that can be low-grade. Much less common in the breast, peripheral nerve sheath tumors are exceedingly rare as primary tumors in the breast, low-grades spindle cell sarcomas, as well as nodular fasciitis, which typically involves subcutaneous tissue rather than breast tissue proper. PASH is a benign myofibroblastic proliferation, most often presents as these slit-like spaces, can be incidental or mass-forming. They're hormone receptor positive, CD34 positive proliferations, typically occurring in perimenopausal, premenopausal women. PASH is a component of the stroma and gynecomastia and can be seen in fibroepithelial tumors as well. Now, some cases of PASH form these fascicles, or we call fascicular PASH, and they can actually form a very well-circumscribed tumor, similar to what you would see with myofibroblastoma. Making the distinction between a PASH tumor or nodular PASH and myofibroblastoma doesn't really matter. These are both benign lesions, so as long as you call it a benign stromal neoplasm. On the other hand, this is another spindle cell lesion that has a somewhat similar appearance to a myofibroblastoma, which with intervening collagen bands and these fascicles of spindle cells. This was CD34 positive and was called myofibroblastoma, actually based on the staining and the appearance. And on the excision, we see this large spindle cell proliferation, somewhat infiltrative, associated with some epithelial clefts hair and spindle cells, so probably not a myofibroblastoma. And when you have this leaf-like growth, we're actually dealing with a fibroepithelial tumor. So it's something that you always want to keep in the back of your mind when you have a CD34 positive spindle cell lesion, because phylloides tumors, particularly malignant ones, will have a lot of stromal overgrowth, and you won't see the epithelial component in the phylloides. So several morphologic variants have been described of myofibroblastoma, and these really have no clinical significance unless you actually call them something else. And here's a list of some of the more common ones which have been described in some examples, such as the myxoid myofibroblastoma, which really has an appearance similar to a soft tissue myxoma. There's one myofibroblastoma that has a smooth muscle phenotype by immunohistochemistry, and it actually looks like smooth muscle on H&E. And then you have some cases that contain so much fat that they have been referred to as lipomatous tumors, and in some cases can really compress the glands and have this infiltrative-like appearance. This is a case of Dr. Murray's that actually she had last week, where you have a palisaded myofibroblastoma, where you really have these verrucae-like structures in the myofibroblastoma. Epithelioid myofibroblastoma is probably the one that will give you the most problems, unless you recognize that this is actually a circumscribed tumor. But if you could see, if you did a core biopsy right through this, and you only had this, you would probably not think of myofibroblastoma right away. Some other clear cell lesion, possibly adenomyoepithelioma. This is a case we studied at Cornell that actually showed the monoallelic deletion by FISH. Again, epithelioid myofibroblastoma can really mimic an invasive carcinoma. This is another case, and particularly invasive lobular carcinoma, as we saw in our case. Can anyone tell which one is which? Which one's the invasive lobular, right or left? This is a hint right here. Yeah, so it's some LCIS. And of course, ER/PR expression, adding to this, can really guide you right down the tubes if you have a small sample and you're dealing with this infiltrative process. So back to our case, this was kind of unfortunately the perfect storm of having this really small sample of tissue which have this infiltrative, these epithelial or epithelioid cells, plus they happen to unfortunately just have LCIS and adjacent tissue, and of course expressed hormone receptors. But again, what could have been done? I think correlation with imaging, as in all subspecialties of pathology, is really essential. Just some take-home points from this case. Myofibroblastoma really has a diverse morphology, and it's important to recognize some of these uncommon variants. The differential is broad, but IHC and morphology usually is enough to point you in the right direction. The morphologic variants I kind of pointed out at the end really have no clinical significance, except for those that can mimic something else, such as an invasive carcinoma. And again, correlation with imaging is really helpful to know that these are typically circumscribed tumors. And I'll thank you for your attention.
Questions?
Yes?
So if you have that circumscribed tumor on imaging, it can never be invasive, no matter what.
I mean, it could be in a lymph node. I would never say never.
But if it were in a lymph node, you would see that on the histology.
Right, most times, yeah. But it's not, it would be very uncommon to have an invasive lobular carcinoma that looks like
And
that.
why is the leiomyomatous variant not just a leiomyoma?
Well, that was, we actually did a study because we were questioning whether there was actually leiomyomas of the breast. Most times we think about them as leiomyomas most often occurring in the nipple, because that's where all the smooth muscle is. We actually did FISH on a couple of cases that did show that deletion. Others have done that as well. But again, it doesn't matter. They're benign. They're both benign lesions. So if you call something benign stromal lesion of the breast, and that those are all in your differential, you'll be fine.
Yeah. So in this era of chemotherapy for patients,
Yeah. Well,
could really go wrong with calling something
not so much. Well,
lobular, or you
right. So
expect
you wouldn't expect
what
people to
kind?
give neoadjuvant chemotherapy to an
It's a large
invasive.
tumor.
Right. Or if there was lymph nodes that are positive, which.
Do you ever get intracytoplasmic lumens in epithelial myofibroblastoma like we would in a, because you showed one cell that almost looks signet ring-like. You know?
Right. I'm not sure what is in that lumen. I don't think it's mucin, but it definitely had that targetoid kind of signet ring appearance.
I just have a question about that specific case. Who initiated the consult? Was it like the radiologist that thought it didn't fit, or?
Well, the patient had the core biopsy at a community hospital outside. The surgery was done across the street, and then when we got the specimen, we realized that it was a circumscribed. It was just not cancer.
And this was a male, right?
This was a female.
Or was there CIS on top of it?
If you had only got an E-coherent, was that positive, negative? An E-coherent staining?
Right. E-coherent, I'm not sure how it would stain these. It would probably be negative.